Welcome to our latest webinar in the webinar series from the ACP. My name is Richard Heywood. I'm the chair of the ACP Trainee Committee, and I'm delighted to welcome you all this evening for this webinar on liver transplant in colorectal liver metastases. Without any further ado, we'll move on to our first speaker. So it's my pleasure to introduce Dr. Aarathi Vijayashanker, who is a senior clinical fellow in HPTP surgery at King's. She's worked in both deceased and living donor settings for about 5 years in some large volume transplant centres that routinely performed liver transplant for malignancies. She's also co-authored the paper on selection criteria for liver transplant in unresectable colorectal metastases. So I think it is an absolutely excellent speaker. So I'll hand over to you, Dr. Vijayashanker, to talk.
Right, thank you everybody for joining in. Today we will be talking about transplantation in the setting of unresectable liver-only colorectal liver metastasis. We'll touch upon a few of these topics. I will not go into a lot of detail of history because Dr. Ross is going to do that for us, but we will be touching upon some of the pilot studies that reignited the interest of transplantation in colorectal liver metastasis, namely the SECA-1 and SECA-2 studies. We'd also look at in detail the recommendations by the Liver Advisory Group of NHSBT for setting the selection criteria for patients with unresectable liver metastasis in the UK who may be eligible for transplantation. And finally, we look at some of the results of the TRANSMET trial. So as we all know, colorectal cancer is one of the most common forms of cancer and cause of cancer-related deaths in Europe. In up to 20% of these patients, they present with synchronous liver lesions, and 50% of them go on to develop lesions within 3 years of their diagnosis. At the moment, for patients who have liver disease from colorectal cancer, the only potential form of curative therapy is liver resection. And we have found median survival ranging from 2 to almost 5 years in these patients. However, unfortunately, only up to 20% of these patients are able to undergo resection with curative intent. And we have found that in patients who have unresectable disease in the liver, the overall survival is only up to 15%, despite modern chemotherapy and immunotherapy. So how do we define resectability in these patients? The definition of resectability certainly has evolved over time. It's no more dogmatic as it used to be. And size and number do not anymore exclude patients from having a liver resection for colorectal liver metastasis. And neither does margin status. We've often seen in literature so far that patients with R1 resection close to critical vascular structures do end up having equivalent results to complete oncological resection, particularly in the background of good response to systemic chemotherapy. Therefore, at the moment, resectability is only defined purely based on a technical safe limit to resection. So I think universally, I think the global community has been quite reticent to offer transplantation to patients with malignant disease, and for good reason. There's always fear of disease recurrence and progression and subsequently wastage of these precious donor organs. There's also risk of developing de novo malignancies while these patients are on immunosuppression. But we should always remember historically, transplantation has only been attempted in patients who have extremely large tumor volume in the absence of modern chemotherapy, which may have been the reason for the poor outcomes. So that was the case until the definition of Milan criteria in 1996, which then opened up the avenue for transplantation for patients with malignant disease, particularly hepatocellular carcinomas. And the surgical community was able to exhibit good overall survival rates of as high as 75% at 4 years in these patients. But it took about another decade for the colorectal community to be open to trying transplantation in patients with unresectable liver metastasis from colorectal cancer. And one of the initial proof of concept pilot studies was conducted by the Norwegian group, and they published their studies in 2013. in which they investigated the potential role of transplantation in providing long-term survival in patients with unresectable liver mets from colorectal cancer. So if we look at their inclusion criteria, it was fairly broad, and they only required that the primary be removed and the patient have good performance status and have had a minimum of 6 weeks of chemotherapy in the absence of extrahepatic disease. And they went on to do consecutive transplantations for 21 patients over a 5-year period. And they followed up these patients for a median duration of 27 months and found that they were able to show good overall survival of 60% at 5 years. However, the disease-free survival was 35% at 1 year. And most of the disease recurrence occurred in the lungs. So this study identified a few poor prognostic factors, including a tumor diameter of more than 5.5 centimeters, time from primary cancer surgery to transplantation of less than 2 years, a high CEA level of more than 80, or progressive disease at the time of transplantation. And this they termed the Oslo prognostic score. So based on this study, they went on to conduct another sequential trial, which was called the SECA-2 study. This time around, they applied a slightly more stringent selection criteria. They expected that the patients who are included for transplantation have at least 10% response to chemotherapy based on the RECIST criteria. And they should, if they had more than 30 lesions within the liver, all of them should be at least less than 5 centimeters with 30% response to chemotherapy. So they conducted this study over a 4-year period with a median follow-up of 36 months in 15 patients, and they were able to significantly improve the overall survival outcomes with this set of stringent selection criteria up to 83% at 5 years, and a disease-free survival of 53% as opposed to 35% previously at 1 year. They again found that most of the recurrences were in the liver and majority of them were amenable for resection. So they went on to identify a few more positive and negative predictive factors through these pilot studies, which then became the basis for the design and conduct of several other randomized control studies. Several of them are still underway. One of the studies, TRANSMET trial, recently published their results, and we'll discuss that shortly. So based on these pilot studies, the international community came out with the first ever consensus guidelines supporting the employment of transplantation for unresectable liver-only colorectal metastasis. With this background, NHSBT soon decided to form a fixed-term working group, which consisted of transplant surgeons, colorectal surgeons, hepatologists, radiologists, histopathologists, as well as patient representatives, in order to outline a criteria that can be used to initiate a program for transplantation for these patients within the United Kingdom. And this was set up in the November 2021. They subsequently recommended that transplantation can indeed be employed as an intervention for these patients through a pilot national service evaluation. And the proposed plan was to transplant between 20 to 30 patients over a 2-year period. And that given how we as a country have found donor organs to be not as freely available as countries like Norway, which is an organ surplus nation, we decided to employ a slightly more restricted selection criteria. And these are some of the members of the fixed-term working group, and we also had 2 international clinicians helping us out with the setting up the selection criteria. And we went on to publish these 2 papers outlining the selection criteria last year. Essentially, our inclusion criteria included histologically verified primary adenocarcinoma in the colon or rectum, which should be fully resected at least 3 months before the patient goes on the transplant list, and they should have had complete resection, essentially R0 resection. And they should not have had any liver resection in the past, and they should only have isolated liver disease with no extrahepatic disease. What was unique about our inclusion criteria, certainly when compared to the SECA 1 and 2 trial, was that we expect these patients to have exhibited sustained response to chemotherapy of up to 30% over a 2-year period. And if in case patients were to progress while they were on a particular line of chemotherapy and they were to move to a second line chemotherapy, that would mean this wait of a 2-year period would then get reset and they would have to wait for a 2-year period again. It can sound quite stringent, but it's something that we are continuing to review by the Liver Advisory Group. The other inclusion criteria are fairly standard with expectation of no evidence of local recurrence or peritoneal disease or any extrahepatic disease with patients who have good performance status. Coming to exclusion criteria, we decided to exclude patients who obviously were having sequentially increasing serum CEAs, which may potentially indicate occult metastatic disease elsewhere outside of the liver. We also decided that patients who have undergone palliative resection of their primary tumor should be excluded. And patients who have had complete response to primary tumors without having undergone radical excision were also excluded from this national service evaluation. We didn't quite think that morphological differentiation and mutational status should be part of the selection criteria because with the employment of a 2-year waiting period, we were already allowing biology to exclude some of these patients. So it didn't feel necessary to use mutational status as a part of the selection criteria. It was also decided that salvage transplantation of patients who've had previously resected liver lesions, liver mets, should be excluded. This is just in order to ensure that the included patients are a little bit more homogeneous so that over the national service evaluation, we're not skewing the results. So these patients will ideally be identified by the colorectal team and then be referred to either the HPV center or the HPV transplantation center, who will then assess these patients for eligibility and then list them for transplantation. In cases of any uncertainty, a national expert panel would be essentially we would refer these patients to the national expert panel, who would have members of the fixed term working group to sort of recommend and review the decision on listing. So the outcome measures that would be studied would include overall survival, progression-free survival, as well as looking at sites and volume of disease recurrence. Quality of life will also be assessed based on validated questionnaires, and the expectation is to have a national registry to record these outcome measures. I will not go into too much detail of organ allocation, but essentially the expectation would be that these patients be transplanted within 3 months of listing, and all organs will be offered to them, including extended criteria donors. The post-transplant immunosuppression would be fairly standard in the first 6 weeks, but there will then be a switch to mTOR inhibitors for their anti-tumoral effects, and steroids would be weaned over a period of 3 to 6 months. These patients will be routinely reviewed in clinic and will have imaging done at regular intervals to look for disease recurrence. So far in the UK, we've managed to transplant 2 patients. The National Service Evaluation kick-started in 2023, and each of these patients have had to wait for a period of 6 months to get a liver, as opposed to the initially planned 3 months, unfortunately. But they've so far been doing well, and 2 more patients are being assessed, and their primary have been removed, and they so far remain stable and hopefully will be listed in the next 3 to 6 months. The protocol for our our selection criteria is constantly being assessed, and instead of leaving a gap between the time of transplantation and the cessation of chemotherapy, it's now been recommended that the patients can continue to be on chemotherapy due to the due to having observed that they are having to wait for a slightly longer period of time on the list. A BMI of 30%, again, because most of these patients do end up being on the higher side of BMI, is being reviewed as possibly being taken off as an exclusion criteria. And we may actually bring down the duration of wait while on chemotherapy from 2 years to 18 months, because to allow the time for these patients on the waiting list to also be a part of this duration. So we'll now talk about the TRANSMET trial, which was recently published in last month in Lancet. The results are from the collaborative TRANSMET group, and it's essentially a prospective randomized control trial, a multi-centric trial that was conducted over 20 centers in France, Belgium, and Italy, looking at the outcomes of patients who undergo transplantation along with chemotherapy versus patients who undergo chemotherapy alone, and in patients with unresectable colorectal liver metastasis. So their inclusion criteria is slightly more stringent and restrictive than the SECA criteria. As you can see here, in addition to the primary being removed, they restricted the lines of chemotherapy that these patients can be on to 3 or less than 3, and they also chose to exclude patients with BRAF mutations due to their poor prognostic value. So over a 5-year period, they initially identified 157 patients who could potentially be part of this TRANSMET study, and after exclusion, they randomized 94 patients. 47 were meant to have liver transplantation along with chemotherapy, and 47 patients were meant to have chemotherapy alone. This was the intention to treat population. But of the 47 patients who were meant to have transplantation, only 37 ended up having the transplantation based on the set protocol. Some of the baseline criteria of the two groups are fairly similar as would be expected. Most tumors were on the left colon, and most of these lesions were T3, T4 with lymph nodal disease. And almost all of these patients had synchronous liver lesions and had a median number of lesions, a median 20 lesions within the liver at the time of diagnosis. So it was found that these patients, so when we looked at the results of the TRANSMET study, the intention to treat group showed an overall survival at 5 years of 56% in the transplantation with chemotherapy group, whereas the patients who underwent chemotherapy alone had a significantly less survival rates at 5 years, and which was only 12.6%. When we looked at the per protocol group and the same results were exhibited, patients had an overall survival at 5 years of 73%, as opposed to 99.3% at 5 years in patients who underwent chemotherapy alone. Looking at progression-free survival, at 3 years, patients who had transplantation and chemotherapy had a progression-free survival of 32% at 3 years. And in the patients who had chemotherapy alone, the progression-free survival was 19.9%. It was found that more than 50% of the recurrences were in the lung, and most of them were amenable to therapy in the form of either resection or ablation, leading to slightly better secondary progression-free survival rates of 36% at 5 years. It was also found that the incidence of post-transplant complications were consistent with that of transplant and routine indications, such as end-stage liver disease or hepatocellular carcinomas. And the toxicity rates of chemotherapy when combined with immunosuppression was also comparable. So in conclusion, I would like to say that we do have increasing evidence of survival benefit with liver transplantation in patients of unresectable colorectal liver metastasis. And we've so far, based on the TRANSMET trial, which has shown a 73% overall survival at 5 years, it matches the globally accepted survival rates for transplantation for conventional indications. However, recurrence continues to be the Achilles heel, but there is promising secondary progression-free survival rates after treatment. Having said that, the UK transplant community continues to be slightly behind the global community by 6 to 8 years, but this is mainly owing to local resource constraints in terms of organ availability. Thank you, everyone.
Thanks so much. That was really interesting. If we have any questions, please put them through onto the webinar chat function. I'll just start us off. From a surgical perspective, when it comes to once these patients have been listed and actually come to having their operation, what's their sort of rate of complications, and is there any sort of particular problems related to the fact they've probably had by that point a couple of years of chemotherapy?
So I think so far we've only managed to transplant two patients, and they've had seamless post-operative course. So that has not been a problem so far. And if we look at the outcome of the TRANSMET trial, in the patients who underwent transplantation along with chemotherapy, most of these patients had up to 21 cycles of chemotherapy prior to undergoing transplantation. And if we look at their post-operative complications, including biliary as well as toxicity related to chemotherapy, the incidences of them have been quite similar to patients who've not had chemotherapy. So that has not been a bone of contention so far. Yeah.
We've had a question from Walid Khalifa who's asked what was the neoadjuvant or sort of the chemotherapy regime used for these patients, and did they then get any chemotherapy after their surgery?
So the expectation is that the patient would be on a particular line of chemotherapy, and I think Dr. Ross will probably be able to answer about the line of chemotherapy. But essentially, most of these patients are usually on doublet chemotherapy, FOLFOX, and some of them are on triplet chemotherapy, FOLFOXIRI. And these patients that we have transplanted so far have not had adjuvant chemotherapy because they've already had 2 years course of chemotherapy. They've not been given adjuvant since their transplantation.
Okay, perfect. Thanks. And I guess the other question I have is from the UK Comet sort of group is how are you sort of trying to encourage people across the country? Because I imagine that this is something that a lot of people in big transplant centres who are having their treatment there would be considered for it, but perhaps at some of the DGHs that are a bit further away from a transplant centre, it may not be something that's on the radar as much. Is there any way that you're trying to sort of broaden the national coverage for it?
So we are sort of trying to reach out to BASO, and we are also trying to conduct a survey just to reach out to these DGHs and other centers who may be able to tell us how many of these patients that they are treating may have unresectable liver mets. And I think that's a way we're trying to reach out to them for them so that we can make them aware of this program. That's one way we're doing it right now.
Perfect. Can't see any more questions in the chat, so I'll hog the questions if that's all right. I guess the other thing I was thinking is we're not calling this neoadjuvant and adjuvant chemotherapy, but when these patients have their livers, their native liver removed, does that then go to the lab and sort of to assess for treatment response and any sort of other aspects like you would do for neoadjuvant treatment in other cancer types?
Yes, I think it's fairly routine, the histopathology, and probably would store steatohepatitis or some form of veno occlusion, but sinusoidal occlusion. But yeah, it would be fairly standard, the post-op histology. Yeah.
We've just had a comment from Louise Graham saying that in Scotland they're trying to increase awareness by attending some of the national meetings. So is there a centralized sort of MDT that people can attend from anywhere?
So there is an MDT that's conducted once in a few weeks on Monday, where patients get referred, and essentially the national expert panel look at essentially reviewing any patients of uncertainty. But otherwise, the MDT would be the routine transplantation HPB MDTs in referral centers.
And just to clarify for that point that this is a UK wide, so this isn't impacted by somebody being in Scotland or Wales or Northern Ireland.
No.
Thanks so much for that. That was really interesting. I can't see any further questions at the moment, but I'm sure. So Fiona Britton has asked, you mentioned the UK is behind with transplantation in this setting. Is there a specific reason you think we have this issue?
So the thing with Scandinavian countries like Norway is that they have an organ surplus situation. That's unfortunately not the case with the UK. So we've had to sort of be more stringent in our expansion of indications because we are observing that particularly with COVID we've had a hit. We've had particularly long duration on the waiting list in many patients with simply end-stage liver disease and hepatocellular cancer. So introducing new indications have been challenging. Along with colorectal metastases, where we've also introduced pilot studies for cholangiocarcinomas and neuroendocrine tumors, so hilar cholangiocarcinoma. So that is one of the reasons why we are lagging behind the global community.
Thank you so much for that interesting talk. And I think what we'll do now is we'll move on to our second speaker, who's Dr. Paul Ross, who's a consultant medical oncologist at Guy's and St Thomas's, who I think will provide a sort of an oncological perspective about this, and may well hopefully answer some of the questions.
I think the question about increasing awareness is actually amongst the oncology and the colorectal oncology community, and beyond the big centres is actually a superb question and a very important issue. And I think it might be something that actually a good meeting to get to a wide audience beyond those who participate at big centres would be having something at next year's oncology forum, and I will take that up with the leadership for that meeting. Anyway, so back to, and I apologise, there's quite a lot of overlap in terms of slides. We didn't sufficiently coordinate. So I'm going to try and, so I'll talk the same set of slides, but try and give you an oncologist view of the world. These are my disclosures. So as you heard said, colorectal cancer is the third most common cancer and cause of cancer-related deaths in Europe. And of course, as we know, this, although the bulk of our workload as oncologists remains in people in the traditional age group, 50, 55 plus, and a lot of those patients indeed 70 plus, we are seeing a growth in a younger cohort of patients, really in their 30s, 40s, but even patients in their 20s and the odd case in their teens. So this question about how do we control advanced disease when it's isolated to one organ becomes increasingly important. And these are the most recent UK statistics from Cancer Research UK, which reckoned we're seeing about 44,000 cases per annum, with just under 17,000 deaths per annum. And actually it was slightly, we're still only seeing just over 50% surviving more than 10 years. And as you have said, approximately 50% of patients at some stage during the course of the illness will develop colorectal liver metastases. And still, even though we've relaxed criteria, a comparatively small proportion actually go on to have radical liver resection. And I think into that these days you have to include other treatments, ablation, SABR, and all the modalities we use to try and clear a liver of disease. Now, when we've, as an oncologist, this is where I'll stop being a transplant. When we see somebody with new metastatic disease, even if it's liver limited, we need to think, what is the intention of our treatment? Is it cure? Is it symptom relief? Or is it prolonged survival? Well, I suppose, although one in this day and age, in particular, we have to use language very carefully when consenting patients to treatment when they've got metastatic disease. If somebody's got a couple of readily resectable or ablatable liver metastases, and I know some would say don't give them neoadjuvant chemo, and that's a separate discussion. But at that point in the MDT, even if we're discussing neoadjuvant chemo because it's synchronous and that, and as an MDT, the collected view, rightly or wrongly, is that there is an advantage to the test of time, if nothing else. Essentially, we're doing it with curative intent. On the other hand, the patient with multifocal liver metastases with no segmental sparing, really, they may have symptoms and you want to achieve symptom relief, but you're also trying to prolong survival. That is clearly treatment with palliative intent. And then, of course, that is the group, the classical group in the middle that I'm not going to focus on in this discussion, that has been the subject of many other discussions over the years, the so-called 30% of patients with potentially resectable disease if they respond to treatment. Now, clearly, as we know, actually it's it's only a minority of those who respond sufficiently well to go on to get resection. So in reality, they fall into the lower burden proportion of those who are treating with the aim of disease control, and where currently the goal is to optimize PFS and overall survival. Interestingly, if transplants on the table, your aim becomes much more focused on progression-free survival. So, as you had said, the history of transplantation for colorectal liver met dates back all the way to the 1960s. Now, and then globally, it came to a grinding halt in 1994 for the reasons that have already been stated. But Capel and colleagues did do some analysis of a small cohort, very small cohort of patients who were transplanted prior to that cessation of resection in the 1990s. And what they found is that patients who did not have micrometastatic nodal involvement were actually living significantly longer and a significantly lower risk of relapse than patients who had had nodal disease by micrometastatic disease. In some respects, not an unsurprising finding, but nonetheless an important observation. So then came the SECA-1 trial that has already been described to you, with 21 patients, 5-year overall survival of 60% and 1-year disease-free survival of 35%, with the majority of recurrences, 13 of the patients who got recurrence, in lung metastases. But Aarathi explained to you the Oslo score, and this graph just shows the graphs show that the significant improvement in outcome if the tumor diameter was less than 5.5 centimeters, CEA less than 80 micrograms per liter. It's been more than 2 years since presentation. You've got disease control rather than progressive disease on your systemic therapy. And this was to do with the number of liver metastases, number of factors, and hence they came up with the Oslo score. And that just gives you a graphical illustration of that as a prognostic model. And then you go to the SECA-2 study, which again you've had described to you already, and the tighter eligibility criteria based on the learnings from SECA-1 and the improved 5-year overall survival and 1-year disease-free survival. And 6 of 8 patients, the initial or only site of recurrence was lung metastases. Now, again, if we look at the prognostic factors, the number of liver lesions was fewer in SECA2, with a median of 5 compared to a median of 8, and that was just reached the criteria for statistical significance. The lesions were small. Dominant lesion was typically smaller at 45 millimeters compared to 24 millimeters, and that has a p-value of less than 0.201. And CEA was also lower with a p-value of 0.015. So then more recently, there's been the Norwegian group have done a combined analysis of SECA1, SECA2, and the so-called RAPID studies. RAPID stands for resection and partial liver segment 2 and 3 transplantation with delayed total hepatectomy. Now, what they do in that trial is they removed segments 2 and 3, the left lateral segment, along with the caudate lobe segment 1. They gave the segment 2 and 3 of the donor organ waited time for organ hypertrophy before removing the right liver segments 4 to 8. In addition, what they over time, there's been a greater use of FDG, PET, and CT prior to transplantation to exclude extrahepatic metastases. And also, it's become increasingly clear that PET defining total metabolic tumor volume for all liver metastases is an important finding. So in this analysis, there were, over that lengthy period of 14 years of this work, they found 72 patients were listed, of whom 61 underwent transplantation, and the median and overall 5-year survivals for the listed are 50 months or 51 months at 42% respectively. And for those who underwent transplantation, the median survival rose to 60 months with a 50% 5-year survival. So, and disease-free survival is 18% at 5 years. So pretty impressive, but given the starting point for the majority of these patients. But still, many patients do relapse after liver transplantation, and the median time to relapse in this analysis was 9 months, and 94% of relapses occurred within the first couple of years, and the median overall survival from time of relapse was 37 months. So that's a pretty favourable outcome, because if you think about it, that is up with international best trials such as TRIBE, if not slightly better. And 5-year survival after relapse is 34 or nearly 35%. And, 30% are alive for more than 5 years after recurrence. So this is much better than would be expected in patients with high burden liver disease. And these are just some of the plots that we've already looked at. So the difference in outcome according to Oslo score, the size of the largest lesion, whether it's less than 5.5 centimeters, status of disease control on chemotherapy, CEA level, and time from diagnosis to transplant. And in this study, they looked at a period 3 or more years versus less than 3 years. And as you can see, and unsurprisingly, there are big separations based upon these prognostic factors. And then further prognostic factors they've looked at include the FONG clinical risk score, one that has sometimes been applied to liver resection, but we're not don't in practice use it in the UK very much. But in a lower risk group with a risk score of 0 to 2, they're clearly doing better than a higher risk group. And this PET metabolic tumor volume again, if you've got less than 70 cubic centimeters of in total of tumor volume within the liver, you're doing significantly better following liver transplantation than if you've got a higher volume. Our primary tumor location again seems to influence outcome. I think that comes back to what was being said in respect to the UK's approach. Biology is important, but do we understand enough about biology? Should we be excluding patients with right-sided disease? In practice, with a longer period of time demanded for disease control, many will exclude themselves. And number of liver metastases, clearly, I suspect, I'm not quite clear why they went for a cut of 9. It seems to me you could have gone to any cuts and probably shown an advantage. So TRANSMET, I just want to go over this again because I think this is really important, because I'm sure a number of you are getting asked about this in your clinics, and because it did get, certainly in the summer at ASCO, it got quite big headlines, and we get, even before that, periodically you have had patients who ask us about liver transplantation. So just think about this. So 157 patients were eligible. Already 63, 2/5 are excluded before you even get enrollment and randomization. Of those who are randomized, obviously, it was an equal split. In the 47 who were included, who went on randomized to liver transplantation, 11 did not receive the assigned treatment, 9 due to tumor progression. In reality, it's 10 because 1 had time between last chemo and liver transplantation was greater than 3 months, so dropped out. And in the chemo alone arm, 9 did not receive the assigned treatment because they went on to transplantation or resection of the bone. So the per protocol analysis was smaller, inevitably. And I won't go back through this because you've had a good discussion on this, but there was a question on what the prior chemotherapy was, and I haven't prepared some slides, but fortunately I do have the data to hand. So inevitably it's presented in the typical form that you may expect to for a publication. So what we know is in the liver transplantation plus chemotherapy arms, liver transplantation arm, 38% had 1 line, 45% 2 lines, and 17% 3 lines. In chemotherapy alone, it's 49, 36, and 15%, respectively. In terms of the drugs given, and we're not told of the precise regimes, interesting type of ongoing, because this is ongoing chemotherapy, it doesn't tell us what, but so 26 and 23% had irinotecan oxaliplatin based, respectively, 43 and 57% irinotecan based, 17% triplet. I guess the low numbers of for fluorouracil are single agent. 35% had anti-VEGF, and 60% had anti-EGFR. So that gives you an idea as to the chemotherapy regimes. And unlike the UK trial, prior surgery was allowed, but actually less than 10% in the transplant arm had prior resection, and half of those were so-called minor hepatectomies, whereas in the chemotherapy arm, ultimately 11% had a minor hepatectomy and 11% a major hepatectomy. So I just thought it might be helpful in terms of where are we up to, what, you know, because I think this is going to be where the discussion really starts to, or one area of discussion is going to focus, is just compare the key eligibility criteria. I've added to this table the Toronto group, another group who've got publications in this area. So the Oslo group, because they started earliest, probably have the simplest and most lax eligibility criteria, but they have changed in their various studies and got tighter. Toronto specify that you aren't allowed, that a tumor cannot be more advanced than a T4A in terms of the primary, and you have to have had at least 6 months chemotherapy, and the time from primary resection to transplant has to be at least 6 months, and there has to be stability or regression of colorectal liver metastases for at least 3 months before screening and until liver transplantation. And they have a CEA cutoff at less than 100 at the final pre-liver transplantation assessment. TRANSMET, just to go back over that, you have to have had a radical resection of the primary, and they stipulate absence of local recurrence on colonoscopy performed within 12 months before enrollment, and stability or regression of colorectal liver metastases for at least 3 months during the last line of chemotherapy, and they don't include patients with CEA at greater. So you have to have a CEA less than 80 at inclusion, or a decrease of 50% or greater of the highest serum CEA concentration. And just to go back through some of the key UK ones, so obviously non-resectable liver only, you have to have an R0 resection of the primary. That has to be performed prior to listing. Performance status is in line with everyone else. The time from primary resection to listing has to be at least 3 months, and absence of local recurrence on colonoscopy performed at least 12 months, particularly if your primary resection has been at some long period before. And you have to receive first-line chemotherapy, achieving a partial response sustained for 2 years. And as you've been told, if you need to switch to second-line chemotherapy, the clock restarts. So this is the Bonnie algorithm that came out of the meeting that was described to you, and I'll attempt to walk you through it, since it's actually, as ever, the oncologists who will be, you know, in many respects conducting the orchestra here and doing a lot of the work up until the point of, other than the transplant listing and the transplantation. So if you've got extra, it goes without saying, just as if you've got, considering resection, if you've got extrahepatic metastatic disease, then it's palliative therapy. If not, you know, then obviously internationally, it's do you fulfill molecular criteria? If not, palliative therapy, yes. Or if you feel there is a question as to whether it's synchronous or metachronous disease. If it's metachronous disease, then you should go on to your bridging therapy. And if there's a response, this study pathway suggests at least 6 months, then you could be transplantable. If there's no response, and by response in this context, they mean stable disease or better, i.e. the absence of disease progression. If, on the other hand, you've got synchronous disease, then there are questions as to whether, if you're asymptomatic in respect of the primary, the initial treatment should be chemo. If there's a response, then resection of the primary with a view to bridging therapy and on to transplantation. If you've got a symptomatic primary, then clearly there may be a requirement to deal with the primary if you don't want to see if the primary related symptoms improve with chemotherapy, which is an option and one that many of us might elect to do in current circumstances. So these are the conclusions I drew, and hopefully we can have some discussion following them. That liver transplant clearly represents a new therapeutic option for selected patients. It unequivocally, in my view, I think the TRANSMET study is absolutely clear. And I think René Adam and the French group have once again stolen a march on the rest of the world in the management of colorectal liver metastases. I think it clearly, in the appropriately selected patients, leads to a significant improvement in overall survival compared to palliative chemotherapy alone. Typically, recurrences are low-burden lung metastases, which respond well to often respond well, and we can control over long periods of time with treatment and may be amenable to ablation or resection themselves. I think the issues that we're going to need to consider are the timing of resection of a primary tumour in patients presenting with synchronous disease, the optimal and appropriate duration of SACT prior to listing. While I absolutely hear what my colleague has to say, I am concerned that what we have done is we're managing the scarcity of organs, as we were being told, actually in preference to really exploring the benefits of transplantation for a group of patients with colorectal liver metastases, some of whom increasingly are, very young patients. And what is the response required? Because what's interesting to me as an oncologist is that because a lot of this work has been driven by transplant surgeons to date, we haven't differentiated, and it may be right, it may not be right, but we haven't differentiated it currently between those who are having stable disease or marginal responses and those who are having formal partial responses by RECIST. And is there a difference in outcome there that could help guide our selection of patients? And indeed, because particularly if you're thinking about synchronous disease, guide, given we know that if you've got an asymptomatic primary, that actually there's no advantage, the trial's been done repeatedly, there's no advantage to resection of an asymptomatic primary if you've got inoperable metastatic disease. So we do need to identify things that would drive us towards should we be resecting those primaries. And will there be a role for ctDNA? I'm thinking particularly of quantitative ctDNA here in patient selection. I would have thought, I'm not an expert in that area, but there will be, there must be some good translational work that one could do there. And the other thing I was thinking, obviously, and for those of you, some of you may know, some of you may not know, I also treat hepatocellular cancer. So I spend a lot of time in meetings where MDTs, where we are thinking about transplantation. But they're a group, the HCC patients have, and the liver services around them have a lot of infrastructure to support those patients with their disease, with the uncertainty, and manage them through transplant assessment and listing and waiting for organs. I ask a question, not that I have an answer. We need those services. Cancer patients have their own needs and psychological support. And how do we bring the expertise of the two together for the benefit of this small but critical group of patients? So I'll stop sharing at that point and happy to take any questions.
We've got one question that's from the previous talk, but I think we could perhaps wait as well to see if there's any questions specifically for that. So the question from the previous talk is, and I suppose links into what you're talking there about where these patients sit generally. So how long do patients normally wait for transplant for other indications, and what's their sort of 5-year overall survival data? So based on this data, should we be prioritizing these cancer patients who have potentially good 5-year outcomes?
So at the moment in the UK, the median waiting time is somewhere between 5 and 6 months on the transplant waiting list for patients with regular indications. And we've seen in the 2 patients that we transplanted with colorectal mets, that's the amount of time they've had to wait. If we look at the countries that have done these studies, for example, Norway, the typical waiting time on the list is somewhere between 1 to 2 months. I suspect in Spain, it probably would be much lower because they obviously have very high organ donation rates. But yeah, that's where we stand in the UK, somewhere between 5 and 6 months would be the median waiting time.
And we've had a really good question here from Anne Tivey. So we talked about donor livers and deceased donors. Is there any option for live donors in this setting?
Certainly there is, yes. But the drive for living donor has not been very much at the moment. We do not have very high volume centers that do living donor liver transplantation within the UK because we have a deceased donor system that works very well. So the numbers are picking up. There are some centers that's doing more and more living donor in adult patients, and hopefully in the future, that's probably how we're going to expand the donor pool. But living donor certainly is an option. It's something that's frequently practiced in Toronto. If we look at their results, most of their patients have gone through the living donor setting for transplantation in colorectal liver mets.
Okay. We've got a couple of questions, people that put their hands up, and I can allow those people to talk. So I'll allow Krishna Menon to talk, to ask a question.
Hi, thanks. I think I missed Aarathi, your presentation. Also I've got a last end of Paul's presentation. I think just to expand on what Aarathi gave as an answer, because it kind of led on this fixed term working group. The question you were asking is, should we therefore prioritize and get these patients transplanted quickly? I think what we have learned is the price you pay for transplanting them quickly is that you have to expect, even with the TRANSMET study, the recurrence rate was 73%, and they will recur in the lung very soon. You're doing a service evaluation, and if your patients recur very quickly, that will not go down very well in terms of continuing with the service evaluation in the wider transplant community, because organs are scarce and we are using it as a precious resource. I think the second option is more attractive, which is why we are pushing on living donation, because it allows for 2 things. It allows for timely transplantation. Once you've decided they've gone past that 2-year window and you want to time the transplant, and you can do it much better if you got a living donor option. So I think mine was not a question, it was really to supplement Aarthi's answers in terms of the questions that were raised. Thank you.
Perfect. Thanks for that comment. I guess the other question I had, and there's a couple more, is in terms of, obviously from an oncologist perspective, this is potentially changing how we approach these patients, because previously, if you consider them as unresectable patients who are on palliative chemotherapy, that impacts your choices in terms of dose reductions and dose intensity and having treatment breaks and things. Have you found for the patients you've done that you have to change how you approach the chemotherapy prescribing for these patients?
Sure. Shall I pick that up as the oncologist on the panel? Neither of the patients done are my patients. I've not been lucky enough to have anybody suitable. Do I think? Yeah, I think the answer is yes. You've got to try and keep going with therapy. I have to say it's probably heresy in the UK to say I've always been something of a well, there's a place for treatment holidays for sure. But we know if you look at the data brutally, you can show non-inferiority in statistical non-inferiority, but it is showing statistical non-inferiority. There is a drop off. The patients do start progressing a bit quicker, but they clearly gain something if they are truly palliative in terms of the break from treatment, the quality of life advantage that offers. So I think if you've got a young patient with colorectal liver metastases, you're seriously asking yourself, well, if this patient remains controlled for another 3-6 months, am I going to be asking the question of the transplant panel? Then you probably, and the patient's coping well with chemotherapy, you probably have to keep going because you have to keep it controlled. And I think, and if they're synchronous, then at some point, I think you almost have to then start having the discussion with the panel. Is this somebody who, if they have the primary resected and then remain stable for a period beyond that and reach the 2-year milestone, because you almost need to start at some point, you've got to introduce the concept to the patient, say why you're going to deviate from our standard palliative pathways, but spell out a lot of the uncertainty. And I was quite interested to see Louise Graham, who's informed us, commented, it might be worth bringing her into this discussion, Richard, employed in the Scottish Liver Transplant Unit as CNS for Transplant Oncology, who's got a background in cancer to offer them support, because there are some real challenges there.
Yes, I mean, this is a brand new post which I've taken up and been in the Scottish Transplant Unit for just about 10 months now, and my main role at the moment is trying to raise awareness with all sort of teams, oncology and HPB teams, about the role of new indications for transplantation. And obviously colorectal mets is one of those new indications, or newer indications. So certainly from our point of view, what we're trying to do is network with all the regions in Scotland and increase the awareness of this indication so that we can try and bring more patients through, if you like.
Louise, my question, Chris or Aarathi, the 2 patients who've been transplanted, we've talked about the timing of it. What we've not spoken about is the difficulties, the young, that I suppose we get to an extent with all patients on liver transplantation. But how do we, it's almost more because, certainly, and I totally appreciate why we've got the UK criteria as they are. But that's a very long time to try and keep somebody with bulky colorectal liver metastases, their disease stable. And how do, have we got any experience of supporting them through that uncertainty?
Happy to answer that if you want me to, Aarathi.
Yes, Prof, go ahead.
Yeah, so I think the 2 patients who got transplanted, both of them waited beyond the stipulated 3 months that we were expecting to get them transplanted by. So they did require a lot of support. And I think what Louise mentioned is really important. I think having a CNS dedicated to this aspect of the service is really important. At King's, we've done that. So we got 1 clinical nurse specialist who helped organize this webinar, Juliet, who's looking after all transplant oncology patients. So I think they require input in terms of the waiting time mainly, because a lot of the times what happens is, moment they hear the word transplantation is going to happen, you have raised their expectations. And during this journey, at some point, if the disease escapes and starts to progress, they fall out of the criteria. So managing those expectations is a challenge. And I think, therefore, having a clinical nurse specialist dedicated for this is really important. I do think that the point about whether we should continue with this burden of disease for a 2-year period of chemotherapy, again, this was debated, and we had experts like Paul Dagline and Renee Adam from the TRANSMET study as part of the expert panel. I think if you look at the time, most patients are waited before they got transplanted. It's around about 17 to 18 months in those studies. So we are looking at that aspect of the delivery of service to see whether or not we can start listing them at 18 months rather than 2 years. So I think that's work in progress. We always said the listing criteria have been published, as it were, but these are iterative, and we will continue to constantly monitor the global strategy in this regard and adjust and make changes accordingly. So that's the reason we're making that change. The other change we have made, and I'm sure Aarthi's pointed this out in the presentation, is that chemotherapy now can continue to the point of transplantation albeit understanding there's a small risk if they get neutropenic sepsis and on the day before the transplant or something, they may actually not be able to proceed with it. So that's the small risk you take when you're continuing with chemotherapy. So I think, in summary, I hope I've answered both aspects of the questions, Paul.
I think that's very helpful. Thank you. Good, I'll let you carry on sharing. It's your meeting.
Okay, I think the other questions involve, I think, have probably been covered about how much chemotherapy and things. I suppose the other thing from a sort of oncology perspective is in terms of your choice of chemotherapy. If somebody presents to you who's potentially treatment down the line, would that impact on what chemotherapy you choose as first line? Because I can imagine that being on 2 years of FOLFOX is not much fun for in terms of peripheral neuropathy and things. So would that impact on what you would choose as your primary treatment?
Yeah, I mean, so my bias, to patients, certainly patients with clearly inoperable disease, and these are patients with inoperable disease, a few maybe in the borderline resectable criteria, is going to be would be FOLFIRI for the would be FOLFIRI. And I might, some you might start with triplet if they seem to be up to it, or particularly if they were symptomatic with disease burden. Obviously, there's a debate about monoclonal antibodies if they've got a left-sided primary tumor location and RAS-RAF wild type, you're clearly going to add an anti-EGFR monoclonal antibody to that. In the UK, by and large, patients are not going to have access to anti-angiogenics. And I think, the debate about the role of anti-EGFR inhibitors in patients with right primary tumor location and other subsets who you might want to add it to, I think is beyond the scope of this evening's debate. So essentially it's going to be FOLFIRI. If you start with FOLFOX, and I would, for some reason, and there are reasons why you might do that, particularly if you're hoping to get them onto a trial which is FOLFOX based, for example, with an added molecularly targeted agent. I think my own view is if they haven't progressed and you switch them to FOLFIRI at some stage because of emerging neuropathy and not because of progression, you have basically continued, but you have modified first-line therapy because they have not progressed. It's managing toxicity, and I think yes, you can argue that there is a bit of an advantage in switching agents in managing resistance, and people have done bits of work on that without showing anything. But I think it's different to some losing disease control and switching because you've lost disease control. And I'm sure one would have an interesting discussion with the expert panel about that.
I'd just like to thank both the speakers for what's been a really excellent, and I think thanks for the people that come on to sort of lead and help with the discussion as well. Hopefully that's been really helpful.